Hi everyone, this is Mr. Neil Reiteter, also known as the Wax Whisperer. Thank you for tuning in to my latest video. For anyone who doesn't know who I am, I'm a UK-based consultant audiologist and clinical ear care specialist. I'm also the founder and director of a company called Clearwax. Clearwax are the manufacturers of the wireless eye clearscope endoscope that we use to perform the procedures and record the procedures that are on my YouTube channel, and also many others. And Clearwax also provide international training in endoscopic ear care, and if you're based in the UK and you're suffering from a blocked ear, feel free to visit our website www.clearwax.co.uk to find your nearest Clearwax specialist. So we have a client here who attended with a very severe outer ear infection. Patient was slightly elderly, so their head was moving a bit. So we just had to ensure that she was steady enough that we can enter the ear safely. When you sometimes have an ear infection, there is a foul smell. There was a really bad odour with this one. And you can see all this debris. It's mainly keratin, dead skin, and that's white in colour. And we've removed 2 huge plugs already, and there's still quite a lot more. And you'd be surprised when we go into the ear just by how much keratin and debris that we do remove. It may not look like a lot initially when I'm suctioning, but you'll be quite, oh, big plugs come out there. So we are quite deep in the ear canal. We're probably about 2/3 of the way in, and there's another piece of keratin there. Now the patient, because of her ear infection, was suffering a lot of otalgia, which is earache, and they're also suffering from tinnitus, which is a ringing and buzzing noise in the ear. So we're just trying to be really careful. As I said, the patient was moving their head slightly. Whenever we perform the procedure, we've always got a brace with the endoscope hand and also the suction hand. So if the patient does make any sudden head movements, we can counteract that. We've got I use my middle finger underneath the patient's earlobe and direct contact with the flesh. So if the patient does move, I can strengthen that middle finger and keep the head away from the instrumentation. So now you can just about see the tympanic membrane posteriorly. So the tympanic membrane is the medical name for the eardrum. So at this stage, the patient's symptoms have significantly alleviated. The sound can get through to the eardrum. What I want to do now is just remove as much debris as possible, a lot of keratin. And this is a piece that kind of surprised me. When I removed this, it was a lot larger piece than I was expecting. And it's just coming away from the anterior recess. So the anterior recess is an alcove, a little trench, cravat, to the front part of the eardrum medially, so near the eardrum is so it's like the ear canal protrudes outwards and then it cuts in and it creates a little hidden getaway, and you can often get a lot of debris there. Again, you can see the patient moving their head quite a lot here, which makes it a lot more difficult. So when the patient moves their head, we're much more likely to come in contact with the canal wall. The patient's ear is already infected and they're already suffering earache. And another plug there. So this is coming inferior. So there's also not only an anterior recess, you can also in some patients get an inferior recess. So the inferior is the bottom part of the ear, and the recess is adjacent to the eardrum, near the eardrum, about 5 centimetre, probably about half a centimetre away. You get a region called the isthmus, which is a natural narrowing of the ear canal, and then it protrudes outwards, and that sometimes causes these recesses. You can see to the top right some granulation tissue. So granulation tissue is a collection of connective tissue, blood vessels that somewhat they're healing, because it's part of the healing process, granulation tissue. And you get a rough red surface, and you can see that top right. And as I clear the ear more, you will see a bit more granulation tissue around the eardrum and the ear canal. So we're using fine end gouge here. Because of the debris, it did on several occasions block the fine end. So the fine end is much more likely to get blocked. We want to use the fine end because we're working near the eardrum, we're working against the canal wall. And because the patient's a bit unsteady with the fine end, if we do come in contact with the eardrum or canal wall, it's less traumatic for the patient compared to the standard zonal suction probe. in my experience, when you have a patient who attends with an ear infection, the more debris, and it's impossible to remove every little last speck of debris, discharge, dead keratin from anyone's ear. If we can remove as much as possible with an infected ear, it will just help hopefully them recover from the infection. So the patient is already on some medication from their GP, but this medication prior to attending wasn't really going to be doing much for the patient because of the blockage. It was so severe that the medication wasn't going to penetrate the flesh of the canal, the eardrum itself. So I went in there and the suction probe got blocked, so I had to come straight back out. So I'm just approaching this anterior recess again, a bit more debris. There's some keratin just at the top, the roof of the eardrum, the attic region. The eardrum itself, you can the landmarks are not as distinguishable as for a normal eardrum. And that's because there is some otitis externa, there's some eczema, some inflammation, infection of the eardrum as well. So we've got some keratin. Now here I have to be very delicate because I don't know whether actually this debris is protruding outwards from the ear canal or if it's just literally coating. So I'm just hovering over it kind of to ascertain the thickness of this keratin, because if I go in too hard, I'm going to go through the keratin onto the bony part of the ear canal. It's going to be very uncomfortable. Same here, so I'm not sure whether this part here is just the bony part of the ear canal or is there some keratin. I can see some kind of ribbons on there, so I'm pretty sure that's some dead keratin coating the bony part of the ear canal, but I'm not sure how thick this keratin is, and I'm just going to be careful. If I go in too hard, I'm going to then penetrate through the keratin onto the bony part of the ear canal and cause the patient some discomfort. So as the procedure stands at the moment, I'm very pleased, alleviated the patient from their symptoms. They will need to continue using their antibiotic drops. But again, I just want to give the patient and the ear drops that they've been prescribed a bit of a head start by clearing as much debris as safely as possible, because you don't be causing any discomfort, trauma to the patient unnecessarily. So I'm happy with that side. So this is just the patient's right ear. So they've got some semi-occluding wax, dead keratin. So I'm just going in with a Zollner suction probe. So remember, this is the same patient, and you can contrast. So this is the patient's right ear. The infected ear was the left, and you'll be able to contrast between the two ears. And if you're watching on YouTube, guys, please do feel to subscribe to the channel, select the bell icon as well, so you'll get notified as and when I upload new videos. Similarly, if you're watching on Facebook or Instagram, please do feel free to like the page, follow, comment, like on the video. So I'm just wriggling this dead keratin out of the ear canal. So the endoscope, the ichthyorscope, is not even in the ear at this stage, it's just being held outside of the ear so we can get the view. So you just got some dead keratin there. It's not going to suction. So I'm just using a fine line to see if I can peel it. With forceps, you can see that this dead keratin is a bit moist. So with forceps, it'll probably just cut through it, slice through it. So when you've got moist keratin like this, it's not dry. Sometimes I use Jobson horn, and you'll see that in a moment. And what I do with the Jobson horn, I just apply some pressure onto the outer part, the outer third of the ear canal is made up of cartilage, so it's flexible, it's semi-sensitive, so we can put a bit of pressure on, whilst the inner 2/3 of the ear canal is literally skin on bone, it's very sensitive and it's non-flexible. So with the flexible part, the cartilaginous part of the ear canal, we can use a Jobson horn sometimes to put some pressure on this skin and almost gently apply pressure and come outwards with the Jobson horn to release the dead skin. And you'll see that in a moment. Dead skin can be really frustrating to remove. This dead skin is not really going to cause the patient any symptoms. It's not going to cause any hearing loss, but because dead skin, obviously the patient had a lot of dead skin in their left ear, and that then got infected. So I just kind of felt I wanted to remove this for the patient, given obviously we know that they've got an infected left ear as well due to some dead cases. So here's the Jobson horn. I'm just applying some pressure to the cartilage portion, and it will just help release some of the keratin of the canal wall. And it's posteriorly. So eardrum's nice and healthy. So if you can remember what the other side looked at, and in a moment you're going to see an examination of both ears. So this is just to recap the patient's left ear. And that's some of the debris removed from the patient from the left side. So I hope you enjoyed that video, guys. Hope you're having a great evening, and wherever you are in the world, you're keeping well and safe. Thank you. Bye.